بسم الله الرحمن الرحيم. موضوع اليوم عندنا موضوع الأوكيولار موتيليتي disorders and strabismus. To understand the ocular motility disorders هنبدأ نشرح الأكشن of the extraocular muscles with different types. Then the different types of the strabismus. We will talk also about the single binocular vision. How to diagnose cases of strabismus and different types of and different forms of ocular motility disorders other than strabismus. First of all, eye movement is controlled by 6 extraocular muscles. We have the medial rectus. It produces adduction, the movement of the globe toward the nose, abduction by the lateral rectus. These are two horizontal recti, medial rectus and lateral rectus. We have superior rectus that produce elevation and intorsion and adduction. It is the main elevator of the superior rectus if the eye is in the abducted position. It is the main elevator. The inferior rectus, it produces downwards movement, which is depression. It produces also adduction and extorsion. And it is the main depressor if the eye is abducted. So these are the 4 recti. The 4 recti originate from the apex of the orbit around the optic foramen from the annulus ring of Zine. They take nerve supply from the oculomotor nerve, except the lateral rectus, which takes nerve supply from the 6th nerve, abducent nerve. Then we have 2 oblique muscles. We have the superior oblique and the inferior oblique. The superior oblique will take origin from the apex of the orbit, and it will pass forwards in the upper inner angle of the orbit at the junction of the roof and the medial wall. So that the tendon of the muscle will pass in the trochlea, and it will be reflected posteriorly and outwards in the upper outer quadrant of the globe. The oblique is inserted behind the equator of the globe. The equator is the area of the widest circumference of the globe. The action of the superior oblique, here we return to the action. The action of the superior oblique is to depress the globe. It is a depressor. It is intortor. It produces intorsion and abduction. It is the main depressor if the eye is in the adducted position. Inferior oblique takes origin from the floor of the orbit anteriorly near the lacrimal fossa, and it passes backwards posteriorly to be reflected, to be inserted into the inferior outer posterior quadrant behind the equator, like the tendon of the superior rectus, but it is below the superior oblique, but it is below the globe. The action of the inferior oblique is elevation of the globe. It produces also abduction and extorsion. It is the only elevator if the globe is in the adducted position. So the globe in the adducted position, the only depressor is the superior oblique. The only elevator is the inferior oblique. If the globe is in the primary position, that's the 2 eyes are looking at a distant target. So the main adductor is the medial rectus, the main abductor is the lateral rectus, and if the eye is slightly abducted, the main elevator is the superior rectus, the main depressor is the inferior rectus. So we have a position in each direction of gaze in which one muscle is only active in each eye. So when the patient looks from the primary position, which is as if he's looking at a distant target in front of his eyes, if he looks to the right, so the right lateral rectus will contract and the left medial rectus will contract. These are the only two muscles that are active in this position. If he looks to the right and up, the right superior rectus is the only active muscle and the left inferior oblique is the only active muscle. If he looks right and down, so the right inferior rectus and left superior oblique are the only active muscle, and the same is in the left gaze position. The gaze position, the left lateral rectus and left medial rectus will contract. Left and up, the right inferior oblique and left superior rectus. Left and down يبقى عندنا right superior oblique and left inferior rectus. So these 6 positions we are going to examine the four recti and the 2 obliques, all the extraocular muscles. Right gaze, left gaze, right and up, right and down, left and up, left and down. So in these positions we will know, you will have an idea in few seconds that these muscles are acting and active or paresed or paralyzed. So we can differentiate by this ocular motility test between the paralytic and non-paralytic types of ocular motility disorders or strabismus. There is other types of ocular motility which is different from the vergence. The type which we described earlier is called vergence, in which the 2 eyes will move in the same direction. There is other type of ocular motility which is called divergence, where the 2 eyes will move in opposite directions, as convergence, which is part of the near reflex. Convergence, accommodation, and meiosis. Also divergence, but in the human eyes the divergence occurs as a corrective divergence from the convergence position to the primary position. There is no divergence from the primary position outwards. This occurs in animals, but in humans it is only corrective divergence. As we said, these 6 muscles are supplied by 3 cranial nerves. We have the oculomotor nerve supplying all the extraocular muscles except the lateral rectus, supplied by the 6th nerve, and the superior oblique supplied by the 4th nerve. The nuclei of these nerves all are present in the brain stem, 3rd, 4th, and 6th nucleus. Other inputs will share in the control of ocular motility, like the vestibular system, vestibular nuclei, and vestibular canals. Vestibular nuclei will give input to the brainstem nuclei of the extraocular muscles to correct the position of the eye according to the position of the head. So if the head moves to a specific direction, it will stimulate the semicircular canals that will give feedback to this nuclei to correct the position of the eye and to make the patient looks at the target and see better without diplopia, without any disturbance of his image. Also, these nuclei, the action of this nuclei is synchronized by other supranuclear control, which is the gaze centers. We have horizontal gaze center, which gives the stimulation or gives impulses to the for example, if you have right gaze, to the right lateral rectus and to the left medial rectus at the same time. This gaze center, the right gaze center, for example, is present in the right side of the brain stem, and it gives directly impulses to the right lateral rectus, and it gives impulses to the left medial rectus through the medial longitudinal fasciculus. This gaze center is responsible for the right gaze. So if there is any defect or affection of this gaze center, the patient cannot produce right gaze. Also, there is left gaze center in the left side of the brain stem. Higher cortical control of ocular motility in the cerebral cortex occurs, and this controls the fine ocular movements, which is the pursuit, حركة المتابعة. When you follow a target, this is called pursuit movement. It is controlled by the occipito-mesencephalic pathway in the parieto-occipito-temporal loop junction. Also, when you finish following a target, you need to refixate another target with a rapid saccadic movement that is controlled by fronto-mesencephalic pathway in the frontal lobe. So this is the control of ocular movement, and its higher supranuclear also control and feedback from the vestibular nuclei and from the cerebral cortex. We are going to discuss strabismus. What is strabismus? Strabismus is ocular misalignment. When you look at a distant target, your visual axis, which is the line from the fovea in one eye, and the target, this line is called visual axis. The visual axis in the right eye is parallel to the visual axis in the left eye. So the eyes will move synchronously and with their visual axis parallel in all directions of gaze. Strabismus is ocular misalignment, where this visual axis, for example, of the right eye is shifted toward the nose, and this is called esotropia. Esotropia أو manifest strabismus. تمام. So the strabismus may be latent or manifest. اللي هو everybody can see the deviation, and it is manifest all the time, and this is called tropia. And this type of strabismus may be constant يعني all the time of the day the eye is deviated, and sometimes it is intermittent يعني the eye deviates for few hours and is in the primary position, and there is no deviation for few hours or few minutes during the day. So it is an intermittent deviation. Latent deviation or phoria, this is the deviation does not appear except if we interrupt the single binocular vision, which we are going to talk about it later on. So if both eyes open, the eyes are straight. If you occlude or disturb the vision in one eye, so this eye will deviate under the occluder or the filter or anything that interrupts the vision. If you remove the cause, the eye will return into fixation. This is called latent strabismus or phoria, الحول الخفي والتاني الحول الظاهر. تمام. The types قلنا esotropia, the eye deviates toward the nose, as in the left eye in this child, the eye deviates toward the nose. How do we know that this eye is deviating? We have something which is called the corneal light reflex. Normally, this corneal light reflex is in the center of the pupil in both eyes. Here, it is not in the center of the pupil. It is shifted to the temporal side, which means that the left eye is deviating inwards. The degree of this shift determines also the angle of deviation. If the eye deviates outwards, so this is called exotropia. Exotropia. This is left exotropia. يعني here you can see the corneal light reflex اللي هو بنسميه برضه هيرشبرج test. It is central in the right eye and it is the reflex is deviating, not central in the left eye. It is at the area between the pupillary margin and the limbus. So this is exotropia. This is hypotropia. The left eye is deviating downwards. And the last type اللي هو hypertropia. So the general types of strabismus: esotropia, exotropia, hypotropia, hypertropia. For example, this child is having left esotropia. The reflex here is central in the right eye, and the reflex of the light, corneal light reflex, is not central in the left eye. This corneal light reflex, we do it by opening a torch or a flash in front of the patient eye for about 33 centimeters, and we notice the reflection of the flash of the light on the corneal surface. تمام. This eye is central and this eye the reflex is not central. They can see the cursor مش كده؟ Okay. So we can also determine the degree of deviation from the position of this reflex. Maybe in the reflex may occur at the pupillary margin, and this is called 15 degrees esotropia. May occur in the middle, like this child, between the pupillary margin and the limbus, and this is 30 degrees of esotropia, and it may occur at the limbus, and this is 45 degrees of esotropia. So according to this introduction, we are going to discuss different types of strabismus and ocular motility disorders, and generally we divide these into the following groups. First group is the non-paralytic strabismus, in which the eye, for example, is deviated like this, right esotropia, for example 15 degrees, and this patient is having no paralysis of any of his extraocular muscles. So if you ask him to move the eyes, the muscles, all the extraocular muscles are functioning in the 6 positions which we said about in the first ocular motility test. And the angle, which is the angle of deviation, 15 degrees, is equal in all directions of gaze. So if he looks to the right and you measure the angle in the right gaze, it is 15 degrees. If you measure the angle in the left gaze, it is 15 degrees. If you measure the angle up, it is 15 degrees. If you measure the angle down, it is 15 degrees, according to this example. So this type of strabismus is called concomitant squint. Concomitant means that the angle of deviation is equal in all directions of gaze, and this type is a non-paralytic strabismus. The second type is, and this is the figure which represents the non-paralytic strabismus, that the angle is equal in all directions of gaze. The second type is the paralytic squint, in which one of the extraocular muscles is paralyzed. For example, if we have the same example, the right eye is deviating inwards, right esotropia 15 degrees, and the patient is looking at distant target. But here it is a paralytic squint due to paralysis of the right lateral rectus. So the right medial rectus takes the upper hand and shifts the globe inwards. If we examine ocular motility for this patient, if he is trying to look to the right eye will stop in the midline, but the left eye will continue to have the right gaze. So we have a very big angle of deviation in the right gaze. If you return to the primary position, it is 15 degrees angle. If he looks to the left, both eyes will move to the left, so he's having a 0 angle in the left direction of gaze. So 15 degrees in the primary position, very big angle in the right gaze because the right eye does not move to the right, and we have zero angle in the left gaze. So different angle in different directions of gaze, and this type of strabismus is also called incomitant. Incomitant is an expression that expresses the different angle in different directions of gaze. It is due to paralysis of one of the extraocular muscle. And this is how it looks in this diagram. Third type of ocular motility disorders that we are going to discuss are circular motility, ocular motility disorders related to lesions above the nerve, muscle, and the nucleus, which is supranuclear lesions in the control of gaze, the gaze pulses, right? For example, horizontal gaze pulses and vertical gaze pulses, or higher cortical controls disturbances, disturbances in the pursuit and saccadic movements. We are going to discuss it in details. Also, other disorders that affect ocular motility, like nystagmus, vestibular affection, and diseases of extraocular muscles, or are going to be discussed. We said this ocular motility test is essential to differentiate between paralytic and non-paralytic strabismus. First, we are going to discuss non-paralytic strabismus, and before discussing the non-paralytic strabismus, we are going to discuss the single binocular vision. Single binocular vision is the sensory component which drives the eyes to move together and synchronously. So the right eye, if you look at a target, distant target, the right eye will have an image of this target. For example, the window, and the left eye will have the same image because there is no squint and the two eyes are looking at the same target. So this is the first degree of single binocular vision, and it is called perception, simultaneous perception. Second, these images will go through from the retina to the optic nerve to the optic chiasma, optic tract, optic lateral geniculate, optic radiations, lateral geniculate body to the occipital cortex, where we have perception of two images. The cerebral cortex will fuse these two images into one image because we will see one image only. So this is the second stage of single binocular vision, is called fusion. The third stage is called stereopsis, or interpretation of the image, and this will determine the depth perception. So this single binocular vision develops during the early 7 to 9 years of life. If it develops, it will persist with the person throughout his life, except if there is something interrupting this single binocular vision. If there is interruption of visual or sensory impulses before the age of 7 years or so, there will be no perception or defective perception in one eye, and this will result in there is no fusion, no proper fusion, and no depth perception. So it will result in a defective single binocular vision. And if this persists to the age above the 8 or 9 years, this eye will not be able to have a clear image, and this condition is called amblyopia, which is defective vision that cannot be corrected, and it is due to a defect in the perception in early years of life. If we have a disease that will shift one eye, that, as we said in the paralytic strabismus, so the right eye is shifted toward the nose, and the visual axis is different from the left eye. If the left eye is looking at the target, as we said, which is the window, the right eye is looking at another target So we have two different images. So the brain will not be able to fuse these images, and we have to suppress the image which is not of interest. And so automatically the brain will suppress the image of the right eye, because this image will produce confusion in the brain, and there is no fusion of the images, because it is different images. For images to be fused, they should be slightly dissimilar, but same image, slightly dissimilar. When the eye deviates, there is totally different image, and so there is no fusion. There is confusion, there is suppression, and prolonged suppression of the image of the affected eye will result in amblyopia. If it persists above the age of 9 years, it will produce permanent defective vision in this eye. Before the age of 9 years, we can treat this amblyopia by occlusion of the sound eye for few hours during the day to force the affected eye to look at the target, and at the same time we put the proper correction for vision as glasses and so on. And this is called amblyopia treatment. When the vision is equal in both eyes, this eye may take later on proper position if we treat the strabismus. Also from the values of single binocular vision is that it produces a single binocular visual field, which is bigger than the unocular visual field, because the nose and the orbital rims limit the visual field in certain direction, and the temporal field in the right eye is big and the temporal field in the left eye is big. And so when you fuse both visual fields together, it will give a bigger single binocular visual field. Also, there are blind spots in the visual field, which is corresponding to the optic nerve, because the optic nerve does not contain the photoreceptors, and these blind spots in the right eye is compensated by the visual field in the left eye, and the blind spot in the left eye is compensated by the visual field in the left eye. So this principle of single binocular vision also can be examined by a specific instrument which is called the synaptophore, اللي هي الستيجز اللي حكينا عنها: simultaneous perception, fusion and stereopsis. So this single binocular vision represents the sensory part of the control of ocular motility. So in the picture now, or the view, we have the muscles, nerves, and the nuclei control the motility. The vision or ocular alignment with single binocular vision, lower perception, fusion, and stereopsis will give the sensory component. The sensory component will drive and will maintain, will give impulses to maintain the eyes aligned, and there is no deviation while you are looking at a target. The type of strabismus we are going to talk about in details now is non-paralytic strabismus. And we said in this type of strabismus, the ocular motility is 3. There is no paralysis of any of the extraocular muscles. There is deviation, and there is angle of deviation that is fixed in every direction of gaze. So there are many causes of this non-paralytic strabismus, but sometimes we cannot find a cause. It may occur in otherwise normal child, but we cannot find a definite cause. Usually it is thought that it is due to abnormality in the higher cortical or higher center coordination of ocular motility. But there are other occasions where we find causes for this non-paralytic strabismus. أغلب هذه الأسباب, there are causes that result in interruption of the sensory component, as we said, of the ocular motility control, because as we said, the nerve component and the central nervous system and the neural component or the motor component of the ocular motility is intact. So here the defect is in the sensory component. Any disease that interrupts vision in one eye will result in blurred image of this eye, and as we said, there will be confusion and will be suppression of this image and will be loss of single binocular vision. When there is loss of development of single binocular vision in children, the brain will not be interested in proper movement of this eye, so it will deviate. So any defective vision in one eye in a child will result in deviation of this eye. Number A is where we have a refractive error in this eye. For example, in cases of anisometropia, where one of the two eyes is weaker than the other, either high myopia, high astigmatism, so the image is not clear, and the left eye is the image is clear. In this example, as we said, the example which we usually will talk about through all the lecture, which is right esotropia 15 degrees. In this example, here the cause is anisometropia. The right eye is myopic or is astigmatic, so there is blurred image in this eye, suppression, loss of single binocular vision, and later on deviation. Number B, if there are ocular media opacities in the right eye, as in our example, it can occur in any eye, but in our example, the right esotropia, for example, corneal opacities, cataracts, preventing a clear image to the retina. Number C, abnormalities of the retina. The retina itself in the right eye is diseased, and so there is no perception of the image properly. Number D, in children with equal hypermetropia in both eyes. As we said in number A, there is inequality in the error of refraction. So one eye is weak and the other is good. In number D, there is equal hypermetropia in both eyes. For example, a child with hypermetropia +7 in both eyes. This child, to see properly, the image of the target in this child falls behind the retina. So to bring the image to the retinal level, he has to perform accommodation, which is contraction of the ciliary muscle. Contraction of the ciliary muscle will increase the globular form of the lens, increase the power of the lens, and brings the image to the level of the retina. So the child with a +7, for example, hypermetropia, equal in both eyes, will have to produce accommodation to see properly. When the image comes to the retina, due to the accommodation produced by this child, usually this accommodation is accompanied by convergence, as we said in the near reflex, accommodation, convergence, and myopia and meiosis. So we have convergence. يبقى involuntarily the accommodation will have some convergence. This convergence will produce deviation of the eyes, so the right eye will have to look at a different target from the left eye. There will be confusion, and the child will stop producing the accommodation, and so the eyes will return to the primary position, but the image will be blurred again, so he will try to accommodate and to stop accommodation until there is breakdown of these mechanisms, and the brain will stop, will continue to give the impulse of accommodation to have a good image, and suppress one of the two eyes to stop the diplopia or the confusion. So we will have deviation of this eye. The deviation of this eye may at first may be intermittent or with activity, with stress on the eyes, and after some time it becomes permanent. This type of deviation, if we diagnose it early and give the child the proper glasses, which, as we said in our example, +7, so he is not in need of performing accommodation. So the accommodation will stop, and the deviation also, which is convergence, will stop. So the eyes will be straight, and there is also phoria, which is straight eyes with glasses. And this type of deviation is called accommodative type of esotropia. So this is a very important type of non-paralytic age strabismus. We will see also these photos for deviation. This child is having left esotropia. Here the reflex in the right eye is central in the pupil. In the left eye, the light reflex is at the limbus. So he's having a left esotropia 45 degrees. This man is having a right exotropia 30 degrees. The light reflex is central in the left eye, and it is in the middle between the limbus and the pupillary margin in the right eye. So he's having right exotropia 30 degrees. In cases of non-paralytic strabismus, how we are going to deal with this patient? First of all, we will take history from the parents. Usually these children are preschool children that come to the ophthalmology clinic because the parents noticed some abnormality in ocular motility or some abnormal deviation of one of the eyes. So we will ask about the cause. They will tell you that there is deviation of one eye. We will ask if it is a constant deviation all time of the day or intermittent. Sometimes it is straight eyes and sometimes it deviates. Also, we will ask about family history of squint, because there are types of squints that runs in families especially, and errors of refraction that runs in families as hypermetropia or myopia. So we are going to ask about when the squint is present, how long the squint has been present, when means during the day, or also association with something, and with fatigue or so on. How long? And also we will ask about past medical, birth, family history of the child, because sometimes the parents will accuse something to be the cause of strabismus, as for example the child had fever and then the eyes become esotropic, or he fall down and the eyes, or had head trauma and then the eyes became deviated. We'll shift to the examination. So first of all, we are going to look at the child. We are going to observe what is the look. Sometimes the child is having epicantic folds, which are folds on above the inner angle of the palpebral fissure, as in the eyes of Chinese, Japanese, and so on. So these angles will give you an impression that the pupils are near each other, and will give as apparent type of strabismus. But this type is not a true strabismus, because if you put the flash of light, the reflex will be in the center of the pupil of both eyes. So the epicanthus will give you impression that there is strabismus, and you can exclude this type by observation. The first step in examination is observation. As we said, we will observe any abnormal features in the face that may resemble or may mimic the strabismus, as epicantic folds that will give us an impression of esotropia while the eyes are straight, because it will cover the inner angle of the palpebral fissure and makes the eyes as if they are near each other, as in the Japanese and Chinese eyes. Facial asymmetry. If the child is having an facial asymmetry, hypoplastic portion of the face, so an eye may be higher in level than the other eye, and this may resemble hypertropia or hypotropia. So we will, if you look at the fixation and with the torch of light, the corneal reflex will be center in the pupil in both eyes, and so there is no deviation. In these cases, it is the facial asymmetry or the folds, epicantic folds, that give you an impression of strabismus, and this is not a true type of strabismus. So in these children with alternating esotropy with non-paralytic strabismus, we have to do different tests, different types of examinations. The first examination, as we said, the ocular motility. The second is the corneal light reflex, and we determined that this type of strabismus is non-paralytic. We determined the type: esotropia, exotropia, hypertropia, hypotropia, and we determined the angle by the corneal light reflex: 15, 30, 45 degrees of strabismus. Tamam. Also, we are going to do examination of visual acuity to determine the vision in each eye, if there is amblyopia or not. Also, we are going to examine the refraction and to know this eye is myopic, hypermetropic, astigmatic. We are going to examine the fundus to see if there is retinal problem, if there is cataract, if there is corneal opacity, any disease that affects the vision in these eyes. Also, we will do a very important test, which is the cover test. There are different types of the cover test, and this test will give us some information about the non-paralytic strabismus. First of all, if the child is presenting with a manifest strabismus, as we said in our example, for example, the right esotropia 15 degrees, we can use the cover test to confirm this deviation and to differentiate it from other types of deviation. So if you cover the left eye, which is taking the fixation, the right eye will take the fixation temporary, and the left eye will deviate under the cover. If you remove the cover from the left eye, the right eye will return to deviation and the left eye will take fixation. So this type of deviation is fixed to the right eye. It is a fixed right esotropy. If you put the cover in front of the left eye and the right eye takes fixation and the left eye under cover deviates, if you remove the cover and this left eye remains deviating, so this type of strabismus is alternating type of strabismus. The child sometimes fixes with the right eye and sometimes fixes with the left eye. There is alternation. During the fixation of the right eye, the left eye is suppressed temporarily, and during fixation of the left eye, the right eye is suppressed temporarily. So we have fixed right esotropia, we have alternating esotropia. Sometimes the parents complain about strabismus, but when you examine the child at the first time, you will find the eyes are straight, because the type of strabismus in this child is intermittent, as we said, in the types of strabismus. So if you cover one eye, you are going to interrupt the single binocular vision. If this child is having a tendency for deviation or phoria or latent strabismus, this eye will deviate under the cover. If you cover the right eye, for example, the right eye will deviate under the cover because you are interrupting the image of the right eye, you are interrupting the single binocular vision, you are interrupting the sensory control of ocular motility, so the eye will deviate under the cover. This type of deviation, if you remove the cover and the eye takes off fixation, this type of deviation is called latent strabismus or phoria. We can use the cover test also to determine the angle of strabismus by using prisms. We have the deviating eye and we have the fixing eye. We can put prisms in front of the deviating eyes and uncover the sound eye till the deviating eye stops from the fixation movement that it takes during the covering the left eye. If the deviation movement or the fixation movement stops, the angle of the prism which we put, المنشور اللي بنحطه أمام العين, is equal to the angle of strabismus. And usually we multiply the angle of the strabismus, which we calculate by the Hirschberg or the corneal light reflex test, by 2. It will give us the power by prism diopters. For example, if we have 15 degrees right isotropia, it is equal to 30 prism diopters of deviation. So this is called prism cover test or Kremesky test. So the investigations that we do, layer examination of visual acuity, ocular motility examination, examination of the determination of the type of the angle and the type of the strabismus and the angle of strabismus, measurement of single binocular vision, as we said, is if there is amblyopia, if there is affection of fusion. Also, we can measure stereopsis. There are specific cards which we give to the child. If he is having deviation, he cannot perceive the depths and he cannot see the pictures in these cards because they depend on the presence of stereopsis. Also, we'll do refraction and we will know the power of each eye, whether it is myopic, hypermetropic, there is anisometropia, there is astigmatism, any error of refraction we will detect to correct it with glasses later on. And we will examine the fundus and the slit lamp examination. So what is the treatment of this non-paralytic strabismus? First of all, we are going to give the child glasses if there is error of refraction. As we said, there is sometimes you may have anisometropia, you may have equal hypermetropia, as we said in our example, +7, If this child with esotropia and hypermetropia, you give him glasses, +7 as his refraction, the eyes will become straight under the glasses. If the eyes become straight under the glasses, so we corrected his strabismus also. We will examine the vision with glasses. If the vision with glasses is okay, 6 in each eye, so there is no problem. If we find that the eyes are corrected but there is defective vision in the deviating eye, this is called amblyopia. So we have to put occluder in front of the sound eye to force the amblyopic eye to get the fixation for a few hours of the day, and then when the vision improves after a few weeks, we are going to stop this occlusion therapy. So first of all, we'll give glasses. Second, we will give occlusion therapy to treat amblyopia if it is present. Sometimes the child is not having an error of refraction, and sometimes you have a deviation that is not corrected by glasses. So we have to go and correct it surgically. We are going to weaken the medial rectus in this example, esotropia, and to strengthen the lateral rectus, so to push the eye to get the central or orthophoric position. So surgical intervention is by recession of a muscle and resection of another muscle. Recession of the muscle which we consider as strong, pulling the eye in each direction, and resection of the muscle which we think it is weaker and the eye is deviating away from it. So this will bring the eye in the primary position again. So the treatment of non-paralytic strabismus: glasses, amblyopia treatment, and surgical intervention. Prognosis is good, and we can correct amblyopia and improve vision and get proper stereopsis in these children and prevent strabismus and amblyopia, and this depends mainly on early screening of these children, especially in the preschool age, where these errors are present, and usually they are not screened because the early screening occurs only at the school age. So preschool children examination is very important. And this is how we do the resection. We cut the muscle from the insertion and we suture it behind its insertion by a distance which is calculated to correct the degree of deviation, and this is called recession. The other example is resection. We cut a portion of the muscle and we resuture the muscle at its insertion, and this is called resection of a muscle. The recession is a weakening procedure. The resection is a strengthening procedure. الريسيشن بيضعف العضلات والريسكشن يقوي الاكشن of this muscle. So we are going to reposition the muscle in its proper reposition the eye in its proper position. We will discuss now the second group of diseases, which are the types of strabismus. Second group, which is the paralytic type, in which in our ocular motility defect we detected a defective movement of one muscle. For example, in this example, the same example, right esotropia 15 degrees, but another patient, he cannot move his eye to the right eye to the right because of paralysis of the right lateral rectus. For example, so we have isolated nerve injury, 3 or 4 or 6 nerve, and we will have limitation of ocular motility in one of the directions of gaze. For example, we discussed the 6th nerve. Now we are going to discuss the 3rd nerve. 3rd nerve paralysis will result. 3rd nerve paralysis will result in deviation of the eye. For example, if we said right 3rd nerve paralysis, all the extraocular muscles of the right eye are paralyzed except the lateral rectus and the superior oblique. The lateral rectus will pull the eye outwards, so it will produce exotropia. The superior oblique will pull the eye downwards, so it produces hypotropia. يبقى exotropia and hypotropia with limitation of ocular motility of all other extraocular muscles. Also, the patients with 3rd nerve palsy may have ptosis and pupillary involvement. So we generally divide the 3rd nerve palsy into pupillary involving and non-pupillary involving 3rd nerve palsy. The pupillary involving type is a dangerous type because the nerve fibers that control the pupillary movement and pupillary reflexes are superficial in the 3rd nerve. So if they are involved early in the 3rd nerve palsy, this means that there is something pressing on the nerve from outside as an aneurysm or a tumor. So this patient should seek neurosurgical advice urgently because this aneurysm, for example, of the posterior communicating artery may rupture at any time and the patient will die. Also, there may be a tumor that is pressing on the 3rd nerve, and so the pupillary involvement is an emergency sign that will make us refer the patient with the third nerve immediately to the neurosurgical department. Fourth nerve palsy, there will be defective depression of the eye in the adducted position, and also there, with the time, there may be hypertrophy of the inferior, overaction of the inferior oblique muscle in the same eye. طبعا there will be a history of diplopia, a history of disease that resulted in this paralysis. And usually there is a long list of diseases that will produce isolated nerve pulses. The orbital causes, neoplasia, vascular causes, diabetes, أشهرهم, hypertension, aneurysm, carotid cavernous fistula, trauma, neoplasia, brain يعني neoplasia, acoustic neuroma, glioma, meningioma, raised intraocular pressure may result in sixth nerve palsy, and inflammatory diseases may affect the blood vessels supplying the nerves, like the sarcoidosis, vasculitis, giant cell arthritis, and so on. So we will investigate what is the cause of this paralysis. What is the treatment? Treatment is the treatment of the cause, and we try to control the diplopia, because this acute paralysis in an adult will, with full developed single binocular vision, will result in two dissimilar images that will produce diplopia. So this patient should cover the eye alternately to prevent the diplopia until there is improvement of the condition, or there is a straightening of the eye. Usually we wait up to 6 months in cases where there is no emergency, no neoplasia, no other causes, until the control of the medical condition as diabetes, hypertension, inflammatory processes, and sometimes it will return fully to the proper position. And if some remaining deviation or residual deviation is still present, we will go and we will fix it surgically. Now we are going to shift to other causes of ocular motility disorders. Now we are going to discuss causes that are related to the muscles. Extraocular muscles may have diseases that affect ocular motility, as the dysthyroid eye disease. In this disease, the thyroid gland is producing multiple problems and symptoms in the body. In the eye, there is infiltration of the extraocular muscles with lymphocytes and deposition of glucosaminoglycans in the muscle. An immunologic process may occur also in this thyroid eye disease. In these patients, the prolonged course of the disease and the deposition of these inflammatory cells and the glucosaminoglycans in the muscles will result in inflammation of this muscle, will result in fibrosis of this muscle. So our example, the same example, a patient with right esotropia 15 degrees, but at this time, this patient is having a long history of a thyroid gland disease. So we diagnose as a dysthyroid eye disease. But in this patient, there is right esotropia 15 degrees. This time, when we do the ocular motility, there is inability of this patient to produce abduction, and there is restriction of abduction in this esotropic patient. But at this time, the restriction of abduction is not due to paralysis of the right lateral rectus, it is due to fibrosis of the right medial rectus. And to differentiate between this restrictive type of esotropia or strabismus from the paralytic type, as we said in the sixth nerve palsy, we have to do a test which is called forced duction test, in which we put surface anesthesia to the eye and we pull the eye with the forceps and we move it in the directions, different directions, If the eye moves freely with you, so this is a paralytic cause of strabismus. If there is abnormality or restriction in abduction of the eye during force abduction tests, so this is called restrictive type of strabismus, or in this case, this thyroid eye disease. We all know that these patients are having a long history of proptosis, affection of vision, diplopia, red eye, lid abnormalities, proptosis, which is also due to the same cause of the deposition of glucosaminoglycans and inflammatory cells in the orbit. Different extraocular muscles may be involved, and we have to investigate. We can do CT scan and MRI to diagnose and to help diagnose the strabismus and the orbital condition. In these patients also, we are not going to neglect examination of vision and preservation of vision, because this patient with this thyroid eye disease may lose vision because of the proptosis and improper closure of the eyelids. So there will be exposure of the cornea, the surface of the eye. There will be ulceration. There will be corneal ulcer, infective keratitis, and maybe endophthalmitis and loss of the eye and corneal perforation. So we have to examine the cornea and the eye frequently. We should examine the optic nerve because of the fear of development of compressive optic neuropathy due to the proptosis and the infiltration of the orbit. So examination of the optic nerve is important to prevent blindness and loss of vision. In this patient, there is proptosis, lid retraction, there is enlargement of the extraocular muscles. Here the medial rectus is hypertrophied, and there is as we said, the long history of thyroid gland disease. The treatment, أول حاجة, we have to keep this patient safe. We have to prevent corneal exposure. We have to prevent optic nerve compression. We can give systemic steroids, radiotherapy, orbital decompression. طبعا all these measures with control of his this thyroid problem. Sometimes the condition stabilizes, but there is still strabismus. We can do squint surgery to correct the strabismus after stabilization of the dysthyroid condition. The second disease is called myasthenia gravis. In this disease, there is antibodies developed against the acetylcholine receptors of striated muscles. It affects females more than males, the age group 15 to 50 years. 40% of patients have only the involvement of the extraocular muscles without systemic manifestations. In this case, the muscle is affected, so this patient will present with right esotropia, the same example as we said to understand the strabismus, for example 15 degrees, but in this case, this patient with myasthenia gravis will have this esotropia at the end of the day. Early in the day, where there is no, where he is comfortable, there is no deviation. At the end of the day, the deviation will appear. تمام. And when we examine the extraocular motility, we will find defective movement of extraocular muscles. This defective movement of the extraocular muscle is corrected if we do ice bag of the deviating eye. It will become straight again. Also affection of other extraocular muscles, like any other extraocular muscle, or the lid muscle also may be affected, and the patient will come with ptosis and strabismus. These patients are usually, we have to do test, which is tensilon test. We have to refer them to neurosurgical department for treatment with pyridostigmine and systemic steroids. Sometimes they also may have systemic manifestations, thymus gland enlargement. They may need surgery for thymus gland enlargement, so they have to have multi-speciality workup to treat these patients. There is no surgery in these cases for strabismus because, as we said, it improves with treatment and it improves with ice bag. The next disease, ocular myositis, which is an inflammation of the extraocular muscle that results in diplopia and pain, especially in movement of the affected muscle. So in this patient, there is, for example, pain in adduction. So the medial rectus is involved. Prolonged inflammation of this muscle will result in fibrosis of the muscle and restriction of the ocular motility in this type of strabismus, like the dysthyroid eye disease, but this patient is not having any thyroid gland dysfunction. Usually ocular myositis is treated, we can do investigations also like CT scan and MRI, and usually the muscle is thickened all over the muscle, not only the bully of the muscle bully as in the dysthyroid eye disease. And the common treatment for this ocular myositis is systemic steroids. Ocular myopathy is a degenerative disease that affects all the extraocular muscle. It is called progressive external ophthalmoplegia, in which the patient cannot move the eye in any direction because of involvement of all the extraocular muscle, all 6 muscles. Also, there is involvement of bilateral superior levator palpebral superioris, so the patient will have ptosis, bilateral ptosis, and frozen eye. He cannot move the eye in any direction. He have to move his head in any direction of gaze to have this gaze. Brown syndrome, it is one of the ocular motility defects in which in this case there is defective elevation of one eye on the adducted position. So the patient cannot elevate, for example, the right eye if the eye is adducted, if the right eye is adducted, for example, in left gaze. This disease is due to a disease affecting the trochlea of the superior oblique muscle, restricting the movement of the tendon of the superior oblique in the trochlea. And we have to do force adduction test to examine the limitation in the up and in direction to diagnose this Brown syndrome, where there is restriction of the movement of the tendon of the superior oblique in the trochlea. And usually, if there is deviation in the primary position, or if the patient is forced to do a head position to overcome the diplopia, we interfere surgically and we do recession or myotomy of the tendon of the superior oblique muscle. Duane syndrome, this is a syndrome characterized by miswiring of the nerves supplying the medial and lateral recti. So when the patient tries to move his eye, for example, in adduction, there is co-contraction of the medial and lateral rectus. Usually, if you do adduction, there is contraction of the medial rectus and relaxation of the lateral rectus. In this Duane syndrome, there is co-contraction of the medial and lateral recti, and this will produce retraction of the globe in the orbit. Retraction of the globe in the orbit will result in narrowing of the palpebral fissure. So this syndrome So this syndrome Duane syndrome is characterized by retraction of the globe, narrowing of the palpebral fissure on attempted adduction. There are different types of this syndrome and 3 types, but it is not of your concern. We will shift to the next level of ocular motility affection, which is the gaze pulses. As we said, the 3, 4, and 6 nuclei are present in the brain stem, and there are horizontal gaze centers and vertical gaze centers that coordinate the impulses coming from the different nuclei. For example, the right gaze center is present in the right side of the brain stem and is responsible for producing right gaze, giving impulses to the right lateral rectus and impulses to the left medial rectus. It will produce contraction of the right lateral rectus and left medial rectus and producing right gaze. If paralysis of this center occurs due to any of the previously mentioned causes, vascular, neoplastic, traumatic, and so on, this gaze center will not be active, and if you ask the patient to produce right gaze, he will not be able to produce right gaze. But if you examine, if you cover one eye and examine the ocular motility in each eye alone, it will be full ocular motility. So the lesion is supranuclear. There is different or other subtypes of this gaze palsy, which is the affection of only the fibers coming from the right gaze center to the left medial rectus in the medial longitudinal fasciculus. So if these fibers are affected by infarction or tumor or so on, so the patient, if he is trying to do right gaze, for example, the right eye will move to the right and the left eye is not going to contract or is not going to move. And this problem is called internuclear ophthalmoplegia. If you examine the left eye motility by covering the right eye and asking the patient to look in different directions, the medial rectus is functioning and all the muscles are functioning. So this type is called internuclear ophthalmoplegia. It is due to a lesion of the medial longitudinal fasciculus. Also, we have this is a graph that shows the gaze palsy and the internuclear ophthalmoplegia. It is a lesion of the medial longitudinal fasciculus. Then we will talk about the vertical gaze palsy, which is Parinot syndrome or dorsal midbrain syndrome. In this syndrome, there is a lesion of the dorsal midbrain involving the vertical gaze or vertical gaze centers. In this syndrome, affection of the vertical gaze center can be due to the causes which we said before: demyelination, tumors, infarction, enlargement of the third ventricle. In this syndrome, there is defective elevation of both eyes. The patient cannot produce up gaze, for example. And there is convergence, retraction, and nystagmus of the globes if the patient is attempting elevation. Also, there is a very important sign in this Parinot syndrome, which is light near dissociation, which is the pupil constricts on accommodation but does not constrict to light stimulation. And this sign is called light near dissociation. Then we will talk about the last part of our talk about ocular motility, which is abnormal ocular oscillation of the eye, which is nystagmus, that is repeated involuntary to and fro movement of the eyes. اهتزازات في العين to and fro. It may be pendular movement, it may be jerky. One eye is rapid and one movement is rapid and the corrective movement is slow. It may be rotatory, it may be vertical, maybe horizontal. So there are different types of nystagmus. There is a physiologic form of nystagmus, which is called the optokinetic nystagmus. When you go in a train or a bus, for example, and you look at the eyes of the person sitting in front of you, he is looking at the different targets during the movement of the bus. For example, the trees or the light signs or the signs in the road. So he is fixing and refixing different targets. This will bring a saccadic and pursuit and saccadic movement of the globe that is continuous so long as he is fixing outside the moving bus. And this is called optokinetic nystagmus. It is a physiologic type of movement. Also, the nystagmus may be congenital, and it may be acquired. Acquired nystagmus means that the person was normal and there is no this involuntary movement is not present, and after some time he develops a disease that resulted in this movement. What are the diseases? What are the conditions that will produce this acquired nystagmus? Cerebellar disease may result in acquired nystagmus. Drugs like barbiturate may result in nystagmus. Damage to the labyrinth may result in nystagmus. Excessive alcohol intake may result in nystagmus. Upbeat nystagmus, as we said, upbeat nystagmus in toxic states like alcohol intake. Downbeat nystagmus may result in from chiarimal formation, cervico-medullary junction, posterior fossa lesion. Demyelinating diseases. All these types are acquired nystagmus. A patient with acquired nystagmus may come to the emergency room and may come to you complaining of oscillopsia, which is his awareness of abnormal ocular, continuous ocular motility. He's complaining that his visual environment is continually moving, and this sign is called oscillopsia. The other type of nystagmus is the congenital nystagmus, which means a child or infant is born with oscillating eyes. There are two main conditions that produce this nystagmus, which are the sensory congenital nystagmus and the motor congenital nystagmus. In the sensory congenital nystagmus, we find a sensory cause, sensory defective vision in this eye, either corneal disease, congenital glaucoma, congenital cataract, congenital anomalies of the retina, congenital anomalies of the optic nerves, hereditary diseases of the retina. So the eyes are trying to fix the object and to see. So there is a congenital sensory nystagmus. And sometimes when you examine the child, you will not find any sensory cause. You will find perfectly normal eyes, and they believe in this type of nystagmus that there is a defective or abnormal control of the higher cortical centers on the extraocular muscle, resulting in this abnormal motility, and this is called congenital motor nystagmus. What is the value of discussing nystagmus in strabismus and ocular motility disorders? The value is that these patients with nystagmus have their ocular involuntary movements stable in certain directions of gaze. For example, it is in the primary position too much. In the right gaze, it is very little. In the left gaze, it is in between. So this patient is having the best visual acuity if he looks to the right. If he looks to the right, the best fixation of the globes and the best visual acuity. So this patient will, to see, have his life activities, he will have left face turn to bring this point, which is called the null point of nystagmus, to bring it in the primary position. So this patient will have this left face turn all the time. So to correct this face turn, we have to bring his null point to the primary position by manipulating the extraocular muscles with recess resect procedures to get the, as in strabismus, to correct his position and to bring his null point to the primary position, the least nystagmus and the best visual acuity. Assalamu alaikum.